Okay, thanks so much for having me here today, and I think we're going to have a lot of fun with this debate. It actually is a very, very great topic to be talking about. So first, a little bit of housekeeping. What does minimal symptoms mean? I honestly don't know. So TR is already pretty confusing. I think symptoms are symptoms. Let's be real, the term minimal symptoms is not going to appear in any guidelines, guys. And so I really think the question behind this debate is, should we be treating asymptomatic TR? I think that's what we're talking about, because we already know that with minimal symptoms, it's sure. So we know that the definition of minimal symptoms is going to be challenging to do. And now some words of caution. So guys, today you're going to hear some tales. You're going to hear about poor prognosis of patients with TR, heart failure, hospitalizations, and death. You're going to hear about symptoms that are developing late in the disease process after RV remodeling has occurred. And then the patients are higher surgical risk and fewer transcatheter options. There are worse outcomes. And we're treating TR too late. This is what you're going to hear. And honestly, this may be true. We may be treating TR too late. But do we know that earlier intervention is going to mitigate these risks? And so really what I'd like you to think about as we talk about this topic is, to treat an asymptomatic patient or a patient with almost no symptoms, we really need to know that the therapy is going to last and that it's going to lead to improved long-term outcomes. We're starting a clock as soon as we intervene on the patient, just like we think about with all other valve disease. So based on what we know, and more importantly, what we don't know, today I'm going to be arguing that if you see asymptomatic tricuspid regurgitation, you should, first of all, don't listen to Steve. Second of all, we're going to be listening to the Beatles today. We're just going to let the valve be. So how are we going to prove that we should let asymptomatic TR be? We're going to review the current treatment options. We're going to look at the guidelines. We're going to look at the data behind the guidelines. And then we're going to look about what's new. So how do transcatheter therapies change the narrative? Because obviously this is one of the reasons that we're having this debate today. It's because of our new therapies. So what do we know about asymptomatic tricuspid regurgitation? We like to work in a field of evidence-based medicine, so let's search and see what PubMed has to say about asymptomatic TR. It kicks the question back to me and said, did I mean to say symptomatic tricuspid regurgitation? So the reality is that we actually don't know a lot about asymptomatic TR. Let's talk about what we do know. We do know that TR is very common, a lot of new cases every year in the U.S. Treatment rates of TR is low. Majority of TR is functional, and atrial and or ventricular. And we know that TR is bad. Increasing TR severity is associated with higher mortality and worse outcomes. And overall outcomes of patients with severe TR are poor. Lower survival, more cardiac events. So what do the guidelines say? We've got medical therapy. We have recommendations about surgery. And then where do percutaneous therapies fit in this mix? Something I want to think about, as we talk about tricuspid regurgitation is that most of it is functional. And if we think about the timeline of functional TR, we start with a patient that has no TR, and then something happens, which I like to say TR instigators. So atrial arrhythmias, left-sided disease or heart failure, atriomyopathies, pacing, that leads to changes in the RA and RV. A vicious cycle started. We have more TR, then we have asymptomatic severe TR, and we eventually land ourselves in this zone of symptomatic severe TR. And I think there is a lot of discussion about, are we treating TR too late when we wait until this stage of symptomatic TR? But the question that I'm going to pose to you is treating severe asymptomatic TR the right time? Or is this also too late and we're just starting the clock earlier? We have to keep the threshold for treating TR pretty high when it comes to treating asymptomatic patients. Do we really need to be targeting TR much, much earlier if we're in the asymptomatic mode? So which strategy is really going to lead to improved outcomes? Optimization is critical. Linda, you showed this in your case earlier today. This is a patient that came to see us, wide open tricuspid regurgitation. This is one of the worst valve views you'll see, huge coaptation gap. You'll see there an atrial flutter. This patient had an A-flutter ablation, and the TR is gone. And so the question is, if we had gone back to that first echo and intervened on the valve, would we have done good for the patient? Or was the approach of getting rid of the cause of the TR the better thing to do? This is a patient with severe biatrial enlargement. Will fixing the TR stop whatever process led to these changes? TR didn't cause left atrial and right atrial enlargement. Fixing the TR is not going to fix this problem. And so when we think about medical optimization for treatment of TR, I think a lot of times medical optimization gets a bad rap because, I say it doesn't work, it doesn't last very long. But medical optimization can work. Maybe we're just starting it too late in the disease process. Now let's talk about isolated tricuspid surgery. Let's go to the guidelines. And we have a ton of recommendations here. That's the good news. Bad news is that most of it doesn't apply to the question at hand. We've got recommendations about left-sided valve surgery, and then patients with symptomatic TR and worsening RV size and function. There's only one recommendation that talks about asymptomatic TR, and that's actually primary TR. We already talked about the fact that most TR is functional, but let's at least look at what the data is behind this recommendation. So we've actually got two references here for this recommendation of asymptomatic primary TR, and we're going to look at both of them. This is the first one. We saw a whopping 61 patients over 5 years, 10% died before discharge, 75% event-free at follow-up, 61% improved functional capacity. Reduced RV dimensions, which is great, but also reduced RV function after surgery. And so treating symptomatic patients, I think, might make sense because we can make them feel better, but can we apply this to asymptomatic patients? It really just feels like a roll of the dice. Good news, we have one other study that we can look at for this recommendation. And so this one, here we go, we've got 15 patients, and the conclusion was isolated tricuspid valve replacement is characterized by poor short and long-term outcomes. So at this point, we're really grasping at straws in terms of the evidence here. Another side note, if you ask an AI program to generate an image for you for grasping at straws, this is what you get, and I thought that was pretty cool. So surgery for asymptomatic TR, I think the data is overall pretty weak. Symptomatic TR, the data is really not that much better. And that's because the overarching theme that you're going to see is that with tricuspid surgery, it is a higher risk procedure. And that's why we have these novel scores for estimating risk before an open heart surgery and isolated tricuspid surgery. And this is incredibly helpful in terms of risk stratifying our patients and understanding, when should we be intervening. But I do pose the question, we have a score that is estimating in-hospital mortality. So when our patients come to see us and we say, okay, before we send you to surgery, we're gonna estimate what your risk is of dying, not dying in a year, not dying in 30 days. We're talking about estimating a score for dying next week. That tells you in terms of, how important this decision-making is. And so, there's a lot of data about isolated tricuspid valve surgery improving, and outcomes are much, much better. The risk is not nearly as bad as it used to be, and I think this is true. But the risks are still there. 3.2% mortality, 2.1% stroke, 5.3% dialysis, 16.8% pacemaker. And we know that dialysis and pacemakers are also associated with TR. So at the end of the day, if the patient's feeling really good and they feel totally fine, they're going to say, why do I need to take on those risks? Is it going to make me live longer? The reality is that surgery does not make us live longer. It's not going to improve survival over time. And so if we're not improving survival by fixing the valve, well, are we at least making sure that it's going to be a long-term, durable result? Again, we're starting a clock when we're intervening on an asymptomatic patient. So is that repair going to last forever? And the reality is that sometimes the repairs are great and they last, and sometimes the repairs don't last. And so in the literature, the TR recurrence is reported as high as 25 to 40%. Now, why does TR recur? Again, we didn't treat the underlying process that was driving the RA and RV enlargement. So are we just chasing our tails by treating asymptomatic TR as opposed to addressing the actual problem? So overall, surgery for asymptomatic TR, I think it's very hard to justify. When you're symptomatic, we know what our goal is going to be, but for an asymptomatic patient, you have to know the result's going to be very durable, it's going to last forever, and that you're going to have improved outcomes. So what do the Beatles say? You see asymptomatic severe TR, we just have to let it be. What about transcatheter therapies? They hold a lot of promise. This was a registry of 472 patients that was compared against another registry of medically managed patient. that showed improved survival and improved survival free from heart failure for patients that underwent interventions. This was from 2016 to 18. And so this is overall very promising, and I think, everyone in the structural world got really excited to see this type of data. But it's a self-reported registry. It's compared against other registries. It's not randomized, and so we do have to take all of this information with a grain of salt and really look at the randomized controlled trials. Similarly, there was, this is a very interesting study that was done looking at possible survival benefit for earlier interventions. So we're going to look at patients who were conservatively managed or underwent tricuspid intervention, either transcatheter or isolated surgery. And it found that if we risk stratify by tri-score, patients who have a low tri-score actually did better with intervention. Patients who had a high tri-score did not do better. But I'd like to point out that in this registry, most patients were severely symptomatic. 65% were NYHA 3-4. And so I think this shows that treating TR too late may not be beneficial. I think there's a threshold where it's futile and we can't change, the survival curves. But I don't think this is data that's really telling us that treating asymptomatic patients will be beneficial. It's not randomized. There's going to be bias in terms of which patients are getting treatments, and it's only 2-year follow-up. If we're treating an asymptomatic patient, we need very long-term follow-up to make sure we're providing benefit. So we have 2 new FDA-approved devices, which is obviously fantastic and very exciting for all of us. I won't spend too much time on the trials because I think these have been reviewed already several times. But we know that TriClip led to symptomatic improvement but did not change the incidence of death or heart failure. And something that we always worry about with edge-to-edge repair is it's hard to predict how much TR we're going to get, TR reduction we're going to get, and how long is it going to last. We're still learning how to predict these factors, and we don't know long-term durability. So if we have symptomatic TR, I know exactly why we're doing TR. It's because we're going to make the patient feel better. But if the patient is asymptomatic, do we really know we're going to help? Do we know that this is a durable therapy? Maybe it's better to let it be. Similar thing with TTVR, with EVOQUE. TR reduction, excellent, improved functional status, a little bit more risk in terms of bleeding and pacemakers. But overall, the benefit is really related to symptomatic improvement. And something else that we notice with TTVR is that RV function does go down. Sometimes the decrease is just a little bit, sometimes the decrease is a lot. So which patient has better long-term outcomes? Is it the patient with severe TR but good RV function, or the patient who has no TR but severe RV dysfunction? I don't know the answer to this question. So if the patient's asymptomatic, maybe it's better to let it be. Transcatheter options hold a lot of promise. They're very safe. They lead to symptomatic improvement, but we don't have long-term outcomes. We don't have data to support treating asymptomatic patients. So if we think about all of our treatment options, if we're trying to treat an asymptomatic patient, we're trying to prevent long-term outcomes, right? We're trying to improve that. So with tricuspid surgery, we think about, are we aiming for improved survival by taking an upfront mortality risk? With TR, are we trying to treat long-term sequelae of severe TR without long-term durability data? And with TTVR, are we trying to prevent complications of RV dysfunction by taking on a risk of RV dysfunction? With asymptomatic patients, there are just too many unknowns. Do we know which intervention is best? No. Do we know which long-term durability of each option? No. Do we know that early intervention is going to associate with less RV remodeling and dysfunction? No. Do we know that early intervention will decrease hospitalizations and death? No. It's hard to look at this valve. Trust me, guys, I don't like tricuspid regurgitation. I want to treat TR as much as the next guy being Steve. I do want to treat asymptomatic TR. That's the reality. But I want to do it as part of a clinical trial. So in conclusion, when you see asymptomatic tricuspid regurgitation, just remember, in your hour of darkness in the echo lab, I'm standing right in front of you, speaking words of wisdom. Let it be. Thank you very much.